let's talk about why atherectomy is essential in calcified lesion revascularization, and let's see how we can give the main concepts of why it is that we see all the cases we see in the cath lab reviews of this year and every year in this great conference. First of all, the modification of the plaque is at the core of angioplasty from the very beginning. You can see how well the Dr. Grunzik had described exactly what happens to the plaque, that this compresses it and opens it and all that. So obviously the natural situation was that initially you needed to have a compressible plaque. And later on, when the plaques become harder perhaps, when we learn more, could we remove some of that plaque? And that's where the calcification comes in. And there's many ways to classify and categorize calcification. And we use the most practical one because all of us do fluoroscopy and cine angiography. If there's no radiopacity or faint radiopacity, we call that mild, not so important, easily to crack in any way. And the more moderate and particularly severe, the so-called tram track, when we have radiopacities in both sides of the vessel, these are really very important calcifications that may not give to a regular balloon, even high pressure balloon, and therefore we have some aspects of difficulty from then on. And you can see an example of a tram track calcifications. There is no dye in the left at the left panel, but you can clearly see the outline of the vessels because there's tremendous calcium, tremendously dense calcium, as well as long calcium. More sophisticated modalities using intravascular imaging in the center, the classic intravascular ultrasound, whatever is bright white, you see, and has a shadow behind it. You can't see really anything, is a typical calcium, very dense in this particular case. In the center of this cross-section of the vessel, you can recognize a catheter. On the right side, you see a very, very good imaging with the OCT, optical coherence tomography. Again, the catheter is in the middle. You see a tremendously clear interface between the lumen and the endothelium, and then you can see how a calcific plaque looks at the OCT. Obviously, you have to get accustomed to the black and white on the IVUS, which most of us are, I would say, and to the orangey tinges on the right side. And I think obviously those are obviously subjected to change and improvement over time. However, what it doesn't change, and no matter how many times you show this slide never gets old because this is a fundamental reason why an angioplasty may have some problems. And we saw in the very last case, if you look at this graph, this is exactly what Dr. Kinney tried to avoid, that the left part of this, stent right here, that was a proximal part, and that was really big. And she really wanted to be able to expand the stent without being impeded by this calcification. Was really a ridge right after this diagonal we saw. So you can see how this stent could be malapposed. Over here could be tremendously underexpanded, and who knows what we may end up distally, which essentially these are the dominant factors that if we are able to shave the calcium, we may expand this thing better, as well as allow this one to not be malapposed. And this is just an example. Why is it appropriate lesion preparation for coronary calcification important? I just show you also, and at the same time, let's say it's on your way to another lesion, your stent may just get banged left and right, as if you try to go to a narrow pathway with a nice suit, let's say, such as this one I'm wearing, and all of a sudden, you get some dirt on your sleeve just because you're banging against the wall is very narrow. Same way the stent, you may get stripped a little bit. They're very, very important polymers, and the drugs eluted from them, and therefore you're going to have a geographical miss of the drug elution later on. Why? Because your stent device was banged and essentially inactivated in certain spots. In general, coronary calcium, particularly severe, this is the red bars, throughout any event, and this is from very nice analysis from our group in the Cardiovascular Research Foundation. You can see that, what are you talking about? Death, cardiac death, stent thrombosis, TVR, MACE, whatever you want to look, calcified lesions, and patients who have them had worse outcomes in general. So not a great idea to have that. And this is from a population of unstable angina and acute MI. What do the guidelines say? What do PCI guidelines say about that? The PCI guidelines include various things. The cutting scoring balloon angioplasty has a class 2B might be considered to avoid slippage during coronary trauma. PCI, for instance, restenosis should not be performed routinely during PCI. May be helpful by the EA PCI, may be useful in calcified rigid ostial lesions. I would say a weak recommendation, nonetheless, one that is existent. Rotational atherectomy is again not a very high recommendation, at high but not too high, class 2A recommendation for heavily calcific lesions. And in the EAPCI 24C statement might technically be required in cases of tight calcified lesions to allow the subsequent passage of balloon and stents, indicating the modification of the plaque. That's what this means. But again, it should not be performed routinely in de novo lesions or instant restenosis lesions. No for routine, but yes for calcific by the guidelines that always we know are very stringent. Laser angioplasty is included also in the guidelines for fibrotic and moderate calcific lesions. Laser is not mentioned for calcification in the EAPCI, the European statement of 2014, should not be used routinely again during PCI. And something that is not mentioned in the guidelines is that something we may see in another case, the so-called off-label utilization of the laser for the I would say for a heavily calcific nodule. And what we don't see in the guidelines is the the orbital atherectomy, because again, not enough data rise to that level. Nonetheless, they are possible. But this is, as you can see, very difficult to get the specific techniques in the guidelines. And nonetheless, they do exist, particularly for tight lesions as an adjunct of lesion preparation to pass the stent and the balloon. Let's go to the rotational atherectomy system. I don't want to stay too much. I want to stay to a relatively recent study, the prepare calc, a modified balloon with the scoring or cutting versus rotational atherectomy, and then followed up with the same type of stent implantation, let's say, so there's no difference there. And the outcome, the most important outcome, is that about 16% in the balloon had to cross over, whereas in the rotablator, they did not. And I think this is a technical study with a technical answer. 16% of the time, if that's what Dr. Sharma is calling the rota regret. You regret you did not do the rotablator. How much is that? How often does that happen? According to the German investigators of the prepare calc, 16%. Not small. How about the orbital? What do we say about this other system that we saw and will see used in some of the cases? There are some differences. For example, the rotational can be used in orthosteals, whereas this is the orbital, maybe not. The compatibilities and all that, I think we discussed that over the cases. You can study it later. There is a review of cases that are not in any way any randomized, 8 observational cases indicating no difference in the overall MACE, etc. Obviously, these are different populations. No wonder this is a newer device. No wonder it's not in the guidelines yet in any way, because it's just developing results. Ultimately, what we really want to achieve is that you have a really good expansion of the lesion, as much as possible, a uniform stent expansion for whatever segment of the vessel you are treating. That allows the stent to atraumatically be inserted into the vessel, oppose well, and do its job by eluting the drug and preventing the restenosis. That is extremely important. What I was talking about, the off-label use of the laser explosion, off-label, not in any guideline. You have a calcific ridge that nothing can expand it. You can see it right here. It's in the middle. Right here remains over there. If right there you do some laser passage of high energy, and at the same time you inject a little dye at the same time that includes a local bubble, let's say, that is possible. It's not recommended by inexperienced users and may actually help you. This is an algorithm for optimal management of coronary calcific lesions of just 2 years ago. And again, there is a lot to be said here. the balloon crossability is a very quick practical aspect. Balloon goes or doesn't go, very easy. And then if it goes, you predilate and you perform imaging, and then you follow it up with a very good predilation with a non-compliant balloon or a cutting scoring balloon, and you demonstrate the optimal balloon expansion. If you have a problem with that, or if you've already detected a lot of deep calcium by your imaging, then you go over here towards the atherectomy. However, if you're non-compliant balloon and ultimately the imaging confirms a good balloon expansion, you really don't need that. You may consider the lithoplasty balloon later. We can, as we learn more, this is another new device, not yet in any guideline, however available and expanding, I must say. If the crossability is no, that is a real problem now, because if you can't even pass a balloon that is deflated, how would you possibly? Then you try with a microcatheter. If it's a yes, then you have a chance with a rotational or orbital atherectomy to sort of go through the lesion. Obviously, no balloon goes, lithoplasty is not going to go. If it's no, you have a little bit of a situation, the direct wire with a rota wire, such as in this very last case Dr. Sharma indicated. If the microcatheter doesn't cross, but goes all the way to the middle of this occlusion and gets stuck at the calcium, let's say, you can still wire the rest of the occlusion most of the time with your dedicated atherectomy wire, and then you can convert to the atherectomy panel right here. If still the answer is no, in the very, very rare cases, Dr. Sharma quoted 1 over 1,000, it may be a couple of more than that, but regardless, you may have this, you may pull out of your pocket this laser bombing that I explained before as a general idea. And ultimately, you're going to end up reaching the optimal balloon expansion. All right? And then again, you potentially utilize the lithoplasty later to make it even better and all that. We don't want to go to all these details. But in general, you don't do the calcific, the calcific lesion treatment by trying to avoid atherectomy, you're going to regret it 16% of the time, and you're going to have unfavorable or non-uniform stent expansion and insufficient drug delivery in a lot more of cases. Let me leave it as such. Let me invite Dr. Ron Waxman to tell us all how we can forget a little bit of those things and just keep it simple for more of the cases. Thank you, Ron.